All right, so today we're going to do the cardiovascular system. This is a precursor to talking about the drugs. We want to just get a little bit of background on the conditions, the function of the heart, and then some of the diseases or disorders or conditions that we might come across. So the objectives are students will define several cardiovascular diseases. We're going to discuss a little bit about etiology, pathophysiology, clinical signs and risk factors of the following conditions: hypertension, heart disease, which will include atherosclerosis, angina pectoris, congestive heart failure. We're going to explain the role of cholesterol and the role it plays in heart disease. We're going to discuss briefly the RAAS system. It's a very complex system, but we want to just take a few looks at it before we talk about the medications that affect the RAAS system. And then we want to learn a few cardiovascular medications related to angina and congestive heart failure that do not appear on the other PowerPoint. So there's only two drugs on this PowerPoint that you want to make note of and make sure that you become familiar with. So the cardiovascular system is basically made up of the heart and the blood vessels, and the function of the cardiovascular system is to circulate oxygen and remove carbon dioxide from the system, provide cells with nutrients, protect the body against disease and infection with our immune system, our white blood cells, stop bleeding after injury by clotting. So we have clotting factors, and then remove waste products out of the blood, kind of transport waste out of the body, transport hormones to cells and organs, transport drugs to cells and organs. So it does many, many important things. The cardiovascular system, um, when we think about it, we think about cardiovascular disease has a variety of diseases of the heart and blood vessels. So there's something when we think about the system and diseases that affect it, we think, well, what's happening? There's something that's obviously not functioning correctly. We can think of it as like a system failure. It could be an electrical problem because the heart is a electrical pump. It could be a functional problem where it's simply, there's a clog somewhere. There could be some hardening, some inflexibility, some increased pressure, too much fluid. There can be an area that's being cut off from oxygen, and so it's dying. But basically, something is not functioning correctly. So system failure, when the heart doesn't contract sufficiently, or there's a blockage, which is atherosclerosis is the blockage. That's usually one of the two main things that could be happening with the cardiovascular system. So those disorders broadly are hypertension, heart disease, angina, congestive heart failure. So roughly, per the CDC, the heart disease is leading cause of death in the US, and roughly 1 to 2 people die every minute in the United States from a cardiovascular disease. It could be a stroke, even though sometimes we categorize that as neurological, but that can happen from that arterial disease. But heart attack, obviously, or heart failure are the main ones. About almost 700,000 people in the United States died from heart disease in 2021. That's 1 in every 5 deaths. So for risk factors for heart disease, this has changed in recent years. There are some variation in the demographics of heart disease, but in general, we do see more heart disease in older males when there's a family history of heart disease. We can see some correlation between hyperlipidemia or high cholesterol. We see correlation between chronic hypertension, cigarette smoking, physical inactivity or obesity. Those people with diabetes have a higher risk of heart disease or cardiovascular disease. Mental stress, if you stress a lot, live a very high stress life, or have another mental disorder such as depression, we see a little bit of a correlation there as well. Contraindications to dental care, generally speaking, and every office might be a little bit different, but generally speaking, you have to wait 6 months after a heart attack. That's myocardial infarction is a heart attack. You have to wait 6 months for clearance to make sure that the patient is good to go, they're stable, we don't have any major medical emergency concerns. Also, if somebody has uncontrolled high blood pressure, we're going to put a pause on treating them. If they have uncontrolled arrhythmia, so their heart is not beating normally, we're going to put a hold on treating them. If they have unstable angina pectoris, where they cannot control the pain and the squeezing, there's something else bigger going on than just your kind of run-of-the-mill angina that somebody would take a nitroglycerin tab for. So then if it's unstable, we will put a hold on seeing them, and uncontrolled heart failure. So, and another thing to just always keep in the back of your mind are the vasoconstrictors, the epinephrine that are used in the local anesthetic that we used. Those are used with caution, but typically they're good for pain management. And that benefit is weighed against the risk of the use of endogenous epinephrine. So what this means, to say it a different way, is if somebody has a heart issue or heart disease and you use epinephrine in a local anesthetic and you control pain, they're not going to create epinephrine in their own body, because we create epinephrine, right? That's a neurotransmitter that exists in our systems. But if they feel a lot of pain and they get all upset and their fight or flight system kicks in, they start pumping out endogenous epinephrine or epinephrine that's within their body. What's the difference, right? So we'd rather give them some epinephrine, have good pain control that lasts a long time, and it's really perfectly safe. If somebody has a significant heart condition, oftentimes we cap it at 2 carpules of lidocaine with epinephrine. So you always want to just check in with your doctor. Periodontal disease and cardiovascular disease studies support and also question a relationship directly associated between periodontal disease and cardiovascular disease. So there are studies that do show more of a correlation, and then there are studies that say not super direct correlation. However, researchers do agree that there's still a lot of work to be done, and it really does make sense that if somebody is building up a lot of plaque in their mouth, they have a lot of inflammation in their mouth, and the blood circulatory system goes through the mouth and then through the whole body, it does make sense that there could be some kind of an effect. And there are quite a few studies that do show some connection there between people with heart disease and periodontal disease. Maintaining good oral hygiene is important for those with cardiovascular disease. It can, even if it doesn't do something magical to improve their cardiovascular disease, it certainly is good for their overall health and for their oral health. Okay, so the first one that we're going to talk about is hypertension. Hypertension is defined as sustained elevation in arterial pressure. So when you think of the blood in the artery and it's pushing against the walls of the artery, the blood pressure, your systolic number is that higher number, so it's sustained pressure on the walls of the artery, and so that's making an elevated number. It's due to the amount of blood in the vessel being greater than the space available. So if you think of a balloon, as you fill it up, let's say a water balloon, if you fill up the balloon with more and more and more water, you're going to have more pressure on the inside walls of that balloon, and it's going to get stiffer and stiffer. Here is a category of blood pressure. I want you to take really close note to the and or category. These are oftentimes come up as questions on exams. And a lot of times we're not trying to be tricky, but to test your knowledge, we might put a normal reading here and a higher reading here or a higher reading here. So for instance, somebody that's elevated is between 120 and 129, and then they can be less than 80. So it's 80 or less. So if just their systolic is above 120, but less than 130, and this stays below 80 or less, then we just consider them elevated. However, if you have somebody with like, say, 122 over 81, that automatically puts them into hypertension stage 1. So you can have one, it's the greater of the two categories. So they can either be in the same, plane, or it can bump them up. If it's an or, it can bump them up to the next one. So that's important to note for future. Here's just another chart that talks about the different levels, normal blood pressure, elevated, stage 1 and stage 2, some recommendations. I don't usually test off of this information, but I do want you to be familiar with it. Helps get to know the condition a little bit better. All right, so we're going to review here. So blood pressure is regulated by the sympathetic nervous system and the kidneys, and the kidneys play a big part when we talk about the RAAS system. So which receptors regulate blood pressure? So here you can see we're isolating into these little areas. This is to indicate the smooth muscle, and we have alpha 1 located on the smooth muscle tissue of the inside. It produces smooth muscle contraction. So we see an effect here with blood vessels, sweat glands, eyes, and intestinal, but we're going to focus on blood vessels for today. So smooth muscle contraction. And then we have beta 1 because we have one heart. And so beta 1 receptors located on the cardiac tissue. This increases the heart rate, so how fast your heart is beating, and contractility, so how strong the heart is beating. As the body's demand for oxygen increases, the blood vessels contract or dilate to direct blood to the area that's requiring more oxygen. So that's why in fight or flight, blood is directed to your legs and arms, your extremities, so that you can sort of run. And it's sort of restricted a little bit in areas where you don't need as much blood. Hypertension is when the force of the blood pumping through the arteries is just too strong. And so we have that pressure against the walls of the arteries. Factors influencing blood pressure. So this is highlighted. Important to know this here. Cardiac output, that means how fast and hard your heart is pumping. Peripheral resistance, how much resistance is being pushed onto the walls of the arteries. And then blood volume, how much liquid is inside the blood vessel. And so those three things all affect the blood pressure reading that you take in clinic. So heart pumping normally, blood flows easily through the vessels. Hypertension, heart pumping harder, blood may not flow easily through the vessels. Okay, the RAAS system. Oh my gosh. Good little video to watch down here. I would encourage it. You do not need to memorize this whole system here. There's a lot going on. But what I would like to draw your attention to are all of these different, this is a flow chart, and all of these different organs release different chemicals and molecules that downstream have an effect on blood pressure. So the RAAS system stands for renin, angiotensin, aldosterone system. And when we learn the names of the medications in class, you'll realize that a lot of those medications are directly connected to this RAAS system. There'll be like blockers and things to different stages. So notice how we have our first stop of the liver. The liver is going to release angiotensinogen. It's a molecule or chemical, and it releases it in response to low blood pressure. Then we need it converted from A1. This is A1. It's oh, I skipped this down here. See, it takes me a minute to remember all these things. So we have different body parts kicking in. So renin is kicked in from the kidneys, decrease in renal perfusion. And so we add renin, and now from angiotensinogen, we have angiotensin 1, but we have to convert angiotensin 1 to angiotensin 2. So now our lungs give us a little bit of help, and they throw in some ACE. From the surface of the pulmonary and renal endothelium, and that binds to it. And now we have angiotensin 2. So angiotensin 2 has all kinds of different effects on the body. It can increase sympathetic activity. It can affect our calcium channel, potassium, water retention. It can affect the adrenal gland and the aldosterone secretion. It can also affect arterial vasoconstriction, increase blood pressure, and then it can affect the pituitary gland and what it secretes as well. So all of this stuff, though, downstream has an effect on increasing um, blood pressure, increasing sodium reabsorption, increasing fluid retention. So there's a lot of medications that they have created to sort of stop the flow before it gets to the point where we have high blood pressure. So it might release fluid, it might um, keep the angiotensin from converting. It might pull out sodium. So where salt goes, water follows. So it might affect the heart rate. So there's different functions. So just sort of read through this, kind of get a little bit of familiar with what it looks like, and we'll talk about it a little bit more in class. Watch this video as well. Okay, 90% of all people with hypertension have no identifiable cause. They could potentially be overweight, they could smoke, they could drink too much, they could have excess dietary sodium. And when we're talking about, oops, sorry, that made noise. When we're talking about excess dietary sodium, a lot of times we're talking about just table salt. There are, some salts out there that are deemed to have some more health benefits, but just your run-of-the-mill iodized table salt is not healthy in large quantities. Physical inactivity as well. So we're going to talk about treatments in class, pharmacotherapy, and then of course there's always lifestyle modification. Quit smoking, reduce drinking or quit drinking, exercise, more fruits and vegetables, less processed and refined foods. Um, all of these things can help lower hypertension. I love this, and we'll bring this back into our PowerPoint for when we're in class. I really love this one. This reminds me of another one I have when we talk about different medications for another condition, but it sort of zones in or zooms in is what I want to say into these different regions and the different functions in these different areas. So when we talk about the kidneys and the kidneys release renin, which converts angiotensinogen to angiotensin. Diuretics increase urine output and decrease fluid volume. So we'll talk about a category of high blood pressure drugs called diuretics, and they work on the kidneys and they basically help to reduce the amount of fluid volume in the blood vessel. ACE inhibitors block formation of angiotensin 2, causing vasodilation, so your vessels get larger, and block aldosterone secretion, decreasing fluid volume. So that's a function of the ACE inhibitor, angiotensin receptor blocker or an ARB, calcium channel blocker or CCB, direct vasodilators, alpha-1 blockers, beta blockers, alpha-2 agonists. So we'll go over this, we'll revisit this when we talk about the different drugs, but just kind of read through and keep this slide in mind, and it kind of will help you summarize the different medications. This is all medications that do different things to treat high blood pressure. Okay, so coronary heart disease, atherosclerosis, the thickening of the internal layer of the arterial wall caused by the accumulation of lipid, or we call them plaque buildup on the inside of the wall of the artery, results in diminished blood flow and oxygen supply to a portion of the myocardium. Cholesterol's role in heart disease. We have lipids, we have lipoproteins, we have triglycerides, we have cholesterol. These are all different molecules that we kind of collectively call, or the lipids. Hyperlipidemia and hyperlipoproteinemia are elevations of plasma lipids concentrations above acceptable normal values. And there's some controversy about this. They used to say, oh, if your cholesterol or your triglycerides are this high, you're at higher risk for heart disease. There are some studies that refute this, that the numbers aren't quite as severe. You're always going to get pushed back and forth on different topics. Statins were a very, very popular medication to reduce cholesterol. Some people um, avidly don't like statins anymore. So there's always going to be some controversy, but you will see a lot of patients in your chair, especially older patients, that could be on a statin drug, and that's for hyperlipidemia. So lipids or fats are important in the diet because they help the body absorb vitamins or fat soluble vitamins insoluble in the blood. So they are transported in the blood in the form of lipoproteins. Lipoproteins are complexes containing different percentages of cholesterol, triglycerides, cholesterol, proteins, and phospholipids. So it's those different variations that are where the concern comes from, the different levels. Triglycerides, synthesized by the liver, cholesterol mostly obtained from the diet, but also it is made in the liver. We actually need cholesterol, we make it. So, sometimes we only think about it as something bad, but we actually do make it in our bodies, and it is actually important for health. We just don't want too much of it. So lipoproteins are kind of categorized into these three categories. VLDL, very low density proteins, low density proteins. These are considered our bad cholesterols, the LDLs. And then HDL, high density lipoproteins, they transport cholesterol to the liver where it's eventually removed from the body. It's considered the good cholesterol because it helps sort of keep a balance in the levels. This is what it looks like if we start to build up plaque, platelets, and fibrin deposits on the inside of the blood vessel, and it starts to narrow the lumen and restrict the blood flow. The big concern, your body sort of adapts to these smaller areas, but the biggest concern is that a piece will break off and cause a blockage somewhere, and that's where you get the heart attack or the stroke. So formation of lipid plaques can continue decreasing the size of the artery. You can get pain, and which ends up being angina. You can get decreased heart function. And then of course the risk of full blockage. Heart disease treatment, reduce risk factors, pharmacological management, so different drugs, revascularization, angioplasty, a balloon angioplasty. That's where they kind of push open the vein or the artery. Stenting, a stent can be placed in different areas, and then a bypass where they take some donor vessels from the leg and they patch it into the heart, coronary bypass surgery. Angina pectoris, it's highlighted because you do need to know this medication. When blood flow is decreased, so this is another disease or condition, when blood flow is decreased and demand exceeds supply, the outcome is ischemic pain or angina, categorized by aching, a squeezing, pressure, or tightness in the chest. Pain sometimes radiates down the left or right arm, up into the neck or the lower jaw. And people typically, when they're in their chair, they know that they have it, and they will take something like a nitroglycerin tablet, nitrostat, nitrobid, and they'll put it under their tongue and they'll let it dissolve, and that helps to dilate the vessels so the pain goes away. Congestive heart failure. Heart failure is the most common Medicare diagnosis. Heart failure is primarily a condition of the elderly. 5 million people in the United States have heart failure. Any condition that causes myocardial necrosis, which is a part of the heart is dying, necrosis, or produces chronic pressure or volume overload and myocardial dysfunction is categorized as congestive heart failure. So any of those things. Inability of the heart to function as a really well utilized pump. So congestive heart failure is the inability of the heart to function as a pump. Causes can be long-term chronic hypertension, different forms of heart disease. Heart failure can occur on the left or the right side, and different symptoms will sort of come after that. So typically if the left side fails, then there's pulmonary edema. Might be swelling or edema in the extremities, the feet. the chest. If the right side fails, then there could be systemic congestion. So it sort of depends. Typically, if somebody has advanced congestive heart failure, they're going to have difficulty breathing. We call that dyspnea. Orthopnea, when they lay back, they may have difficulty laying back in your chair. Um, there's going to be, for a right-sided congestive heart failure, there could be more peripheral edema. And something happens that they call pitting, where you push on, the legs or the ankles. And because there's so much fluid accumulation, when you gently push with your finger, it leaves an indent. That's called pitting. And we talk about this a little bit more in special needs, but this is just sort of a beginning to be introduced to the topic of these different heart conditions. So signs, perceived shortness of breath, dyspnea, exercise intolerance, because can't walk upstairs, can't walk uphill, or move very fast, fatigue, edema is that fluid accumulation, weight gain or increased size of the abdomen. Here's that pitting that I was telling you about, swelling in the feet and legs, leaves an indent when pushed. So treat underlying medical problems. So if there's hypertension, atherosclerotic heart disease, diabetes, if they smoke, control weight, exercise, moderate, or what the patient can tolerate, adequate rest, avoid alcohol. In late stages, they might have to have some dietary restrictions as well. So this is a really important medication for you to learn and memorize. And it's just in this PowerPoint because we used to have a guest for the cardiovascular PowerPoint, but they are not doing that anymore. And so I had to add this here because they didn't have it in their other PowerPoint. So anyways, diuretics may be used for mild congestive heart failure, particularly a loop diuretic. That's an important point to memorize. That's a quiz question or exam question. Cardiac glycosides, digitalis glycoside, increase heart contractility. So this drug helps the heart beat harder, stronger, reduces edema, because that's why you get the edema is the heart's a weak pump. It's not pumping, so then there's acute fluid accumulation. Some very important side effects that go with digoxin or digitalis, however, whichever drug name you have, is gagging. So if someone's taking digoxin and you're taking x-rays, they might gag more. If you stick your mirror down to retract their tongue, they might gag more. And then we want to have caution with local anesthetic and epinephrine. Other drugs that they might be possibly taking if they have congestive heart failure, vasodilators, ACE inhibitors, ARBs. This is another high blood pressure medication, and beta blockers, or any kind of a sympathomimetic drug, which is oh my gosh, there's too many words now. Okay, never mind. I'm not going to say it. But adrenergic. Oh my gosh, that's what I wanted. I was like, the word left me. But it's an adrenergic agonist is the mimetics. So you want to think of other things that could potentially be in that category. For arrhythmias, various abnormalities in the heartbeat, arrhythmic agents are divided into 4 groups. Their specific actions of these agents are complicated. We don't really go deeply into the different drugs for arrhythmias. They work by depressing parts of the heart that are beating abnormally. Patient care considerations, sometimes they have a heart monitor. They have to record the beat, keep checking blood pressure and pulse, record any type of arrhythmia and the drug therapy that they're taking. Be aware of bleeding disorders and for certain medications. And then these are things to think about for our next PowerPoint for the cardiovascular unit. What type of cardiovascular medication can cause gingival overgrowth? What type of cardiac medication can cause a lichenoid reaction of the oral mucosa, and what is a lichenoid reaction? How many cartridges of local anesthetic can be safely administered to a patient who has a cardiac condition? So these are just some primers, things we want to know, probably will be tested on the exam. And that's it for this lecture bite. Thanks for listening.